My name is Kjeld Schmiegelow. I'm a professor in pediatrics and pediatric oncology at the University Hospital Rigshospitalet in Copenhagen. And I've been chairing the Nordic leukemia treatment program for 10 years until 2018. And that includes a number of studies on asparaginase. And we basically see two kinds of challenges. One thing is the recognition of the need to use asparaginase as part of our therapy. And the other is, what do you do when patients develop severe toxicities? So when it comes to the first part, about how necessary it is, there's a large number of studies, including meta-analysis, that demonstrate that if you truncate therapy for whatever reason, or if patients don't get any effect out of the treatment due to silent inactivation due to antibodies, then the risk of relapse is much higher. And there are certain subsets among adult patients, including T-cell leukemia, where they have a higher risk of being treatment resistant or a higher risk of having CNS involvement. And in these scenarios, a number of data sets demonstrate that asparaginase can be quite critical. Now, when it comes to the burden of toxicities, the toxicities that we most frequently see differ in frequency among children and adults, are nearly all asparaginase associated. This includes hypersensitivity, thromboembolism, hyperlipidemia, pancreatitis, and osteonecrosis. So it's much more frequent that adults, except for the hypersensitivity, face toxicities where they need to reconsider, should we stop therapy or should we continue the treatment as protocolized? So we've done a number of studies together with adult hematologists trying to demonstrate that it is in most cases safe to re-exposure. So in case of thromboembolism, including CNS thrombosis, data are quite convincing that with low molecular weight heparin, it's safe to re-expose the patients to asparaginase. When it comes to pancreatitis, we know that the risk of having a second case of pancreatitis is much higher than the risk of having the first episode. And that risk seems to be somewhat higher in the older patient group. However, the risk of relapse is also higher in the adult patients. So we feel that this counterbalances each other. So in every case where you have a patient that early on get truncated therapy, you need to reconsider, what do you think is the greatest risk for my patient? Is the risk of relapse because I truncate therapy? Or is the risk of re-episode of pancreatitis because I re-expose? And when we use long-acting, for instance, pegylated asparaginase or calaspargase, then it's still only 1/3 of adult patients that develop a second episode even after the first dose. And in total, it's in the order of 40 to 50%. But that means that half of your patients can tolerate a new exposure and thus have a higher chance of getting cured of their leukemia. When it comes to hypersensitivity, clearly, if it's a reaction towards the pegylated asparaginase, we know that these patients will always not just have the clinical reaction, but also inactivate asparaginase. So you need to shift to a second-line formulation, and that will, in nearly all cases, be a vinea-based asparaginase. So in Europe, we use Erwinaze. In the US, you mostly use Rylaze. But both these drugs are relevant substitutions. And we know from large pediatric studies that if you replace in case of hypersensitivity, you will fully preserve the high cure rate. So you could say fully compensate against this hypersensitivity. So we regard this as an essential drug that needs to be given to patients of every subtype of ALL, and that although toxicity is a major clinical challenge, you can, in most cases, accept re-exposure and should do it if the anticipated risk of relapse is high. If you have a patient with very low risk leukemia, let's say they are in MRD negativity after induction therapy, it may in some cases be safe just to truncate the asparaginase.